I am Dr. Mansoura, Professor of Rheumatology and Rehabilitation. Today we will talk about osteoarthritis. This topic gained its importance from the fact that osteoarthritis is the most common joint disease affecting humans and the leading cause to chronic disability in elderly. First, what is meant by osteoarthritis? It is chronic degenerative disorder characterized by gradual loss of articular cartilage accompanied by hypertrophic reaction in the subchondral bone and at joint margin in the form of new bony growths called osteophytes. Osteoarthritis is classified into primary and secondary osteoarthritis. Primary or idiopathic osteoarthritis commonly affect particular joints in old age. It is either localized or generalized. Generalized osteoarthritis is polyarticular form of primary osteoarthritis in which most patients have 4 or more joint sites symmetrically involved in the typical distribution for osteoarthritis. The most commonly involved joints are interphalangeal joints of hands and first carbo-metacarpal joint with the spine, knees, hips, and first metatarsophalangeal joint involved in descending frequency. On the other side, secondary osteoarthritis occur as a result of previous joint damage which predispose to osteoarthritic changes. Several disorders are well recognized as causes of secondary osteoarthritis like traumatic causes as fracture across the joint, ligament injury, or even post-surgical as post-meniscectomy. Also, inflammatory joint diseases as rheumatoid arthritis, septic arthritis, and gouty arthritis. In addition to metabolic diseases as hyperparathyroidism, acromegaly, and hemochromatosis. Lastly, congenital anatomic abnormalities as inequality of leg length, angular deformity, hip dislocation, or even scoliosis, as these abnormalities lead to abnormal load distribution which predispose to osteoarthritic changes. Unlike primary osteoarthritis, secondary osteo can affect any joint at any age. We will discuss in details primary osteoarthritis. But as the main pathology is degeneration of articular cartilage, we will start by brief account on structure and metabolism of normal articular cartilage. The articular cartilage is composed of functional matrix with few number of cells called chondrocytes, which is responsible for synthesis and maintenance of matrix. Besides the chondrocytes, which constitute 2% of cartilage volume, there is the extracellular matrix. The extracellular matrix consists of 3 components. Number 1, network of collagen fibers, which is responsible for tensile strength of articular cartilage. Number 2, large aggregates of proteoglycans responsible for stiffness, elasticity of cartilage and its ability to withstand loads. Water, which constitute 70% of cartilage volume. Normally, there is synchronized balance between anabolism and catabolism of articular cartilage. Chondrocytes sense any matrix loss and respond with adequate reparative process. This balance is disturbed in primary osteoarthritis. Although the cause of primary osteoarthritis is still unidentifiable, multiple risk factors are known for development of osteoarthritis. The strongest risk factor is age. As with advancing age, there is decrease in the water content and the glucose aminoglycan content of cartilage. These changes facilitate the development of the disease. Genetic factor. Family risk studies show that genetic factors play a role in the development of generalized osteoarthritis. Regarding the sex, both sexes are affected by OA, but generalized osteoarthritis is commoner in females, especially after menopause. Obesity is a clear risk factor for development of osteoarthritis, especially the knee, and to a lesser extent the hand and the hip. Why? Due to increase the force applied to weight-bearing joints and alteration of mechanical load, beside a metabolic factor, as the adipose tissue is a source of pro-inflammatory mediators which have negative impact on the chondrocytes. Physical activities with repeated overload on the joint or repetitive use of particular joint groups are considered a risk factor for development of osteoarthritis, as seen in some occupations and sports. For example, basketball player and knee joint. Again, cartilage loss is central to the process. It is not a wear and tear process, but there is strong evidence that biomechanical stressors induce chondrocytes to secrete excess matrix metalloproteinase enzymes, which account for majority of cartilage loss. Early in the disease, the chondrocytes increase the synthesis of proteoglycan as a compensatory mechanism, but the newly synthesized proteoglycan is abnormal in composition and aggregate less easily. But later on, the degradative enzymes break down proteoglycan faster than it can be produced by chondrocytes. So the proteoglycan content of the articular cartilage decrease, resulting in thinning and fissuring and cracking of cartilage. So under the microscope, osteoarthritis manifested first by irregularity and fibrillation of the cartilage articular surface. As the disease advances, vertical clefts develop and gradually increase in depth until there is loss of the whole thickness of the cartilage, exposing the underlying bone. Cartilage breakdown products induce or activate the innate immune system and phagocytosed by synovial macrophages, with subsequent release of inflammatory cytokines as interleukin 1 interleukin 6, tumor necrosis factor alpha, resulting in synovitis. Under the microscope, there is mild, patchy inflammatory changes of synovial membrane with synovial hypertrophy and hyperplasia, and mononuclear cell infiltration with plasma cells and lymphocytes. Also, the capsule shows fibrosis and contracture. Regarding the bone, there is bone remodeling and hypertrophy, resulting in increase the cellularity and vascularity and density of the subchondral bone, what is called subchondral sclerosis. Beside bony outgrowths at joint margin called osteophytes. Sometimes the subchondral bone is interrupted by cysts, which is in continuation with the joint space. Distribution of joint affection in primary osteoarthritis. Pattern of joint involvement is an important point in the differential diagnosis of arthritis. Primary osteoarthritis prefer certain joints for involvement. Joints typically involved in primary osteoarthritis are knee joint, lumbar and cervical vertebrae, hand joints, hand interphalangeal joints, proximal interphalangeal joints with overlying bony nodules called Butcher's nodes, and distal interphalangeal joints with overlying bony nodes called Heberden's nodes, and first carbo-metacarpal joint. The first metatarsophalangeal joint in the feet, hip joint, and acromioclavicular joint. Joints rarely involved in primary osteoarthritis include ankle joint, shoulders, and lateral metatarsophalangeal joints of the feet, wrist, and metacarpophalangeal joints of the hand. So, what is the difference between joint involvement in hand between rheumatoid arthritis and osteoarthritis? In rheumatoid arthritis, distal interphalangeal joints are not involved. Metacarpophalangeal joints and wrist joints are commonly involved, while in osteoarthritis, distal interphalangeal joints are commonly involved, while metacarpophalangeal joints and wrists are rarely involved. Regarding the clinical features, joint symptoms, there is no correlation between joint symptoms and radiological features. The common symptom of osteoarthritis is joint pain. It is insidious in onset, intermittent or variable in nature, good days intervening with bad days, worsened by exercise and weight bearing, and relieved by rest. The question: as the cartilage is as the articular cartilage has no nerve supply. So, what is the source of pain in osteoarthritis? The answer: pain arises from several structures, as bone due to pressure on the exposed bone or trabecular microfracture, also from synovium due to synovitis, from ligaments, from capsules due to capsulitis or capsular distension, and spasm of surrounding muscles. Also, the patient can complain from inactivity stiffness, which is stiffness for few minutes after any period of rest, which is called gelling. Morning stiffness is usually not a prominent feature in osteoarthritis, and when present, lasting no more than 15 minutes. This is in the contrary to rheumatoid arthritis, where one of the diagnostic criteria of rheumatoid arthritis is morning stiffness more than 1 hour. Also, the patient complain from limitation of movement and activity. That's due to irregularity of joint surface, muscle spasm or contracture, or even joint lock due to detached osteophytes or loose bodies. Sometimes the limitation of movement may be due to pain or muscle weakness. On examination, we may find diffuse swelling due to synovial thickening or effusion. Moderate effusion is better detected by patellar tap test, while minimal effusion can be detected by milking test. Also, we can palpate bony localized swelling as seen in this figure overlying the distal interphalangeal joint, which is called Heberden's node, or bony localized swelling overlying the proximal interphalangeal joints, which is called Butcher's nodes. Also, there may be localized cystic swelling on the posterior aspect of the knee joint, which is called popliteal cyst, or cystic localized swelling on the upper medial aspect of the tibia at the level of tibial tubercle in case of bisancernous tendinopathy. Wasting of muscles acting on the affected joint is a common finding. For example, in case of knee osteoarthritis, there is quadriceps wasting. The thigh circumference is measured 15 cm above the tibial tubercle to assess for the muscle bulk. Deformity may be found as flexion deformity of the knee, genu varum, as seen in the figure, due to more cartilage loss from the medial compartment, joint laxity or joint subluxation, there is joint tenderness on palpation of the joint line and on the surrounding muscles. Also, there is joint crepitus. What is meant by joint crepitus? It is cracking or grinding noise felt on movement of the knee joint. This is due to the irregularity of the joint surface. Plain X-ray is the gold standard, for diagnosis of osteoarthritis. Radiographic osteoarthritis is at least twice more than symptomatic osteoarthritis. This means that changes seen in X-ray doesn't mean that osteoarthritis is the cause of patient pain. The characteristic findings are non-uniform joint space narrowing, as the joint space is narrower in the medial compartment than the lateral compartment for knee joint. Also, there is subchondral bone sclerosis, subchondral bone cysts, marginal osteophytes. There is no erosions in osteoarthritis except for the rare subtype which is called erosive osteoarthritis, and this rare subtype have a characteristic central bone erosions. In the figure on the right, black arrows point to the subchondral sclerosis, which is seen as whitish discoloration of the bone of the upper end of tibia adjacent to the cartilage. White arrow points to marginal osteophytes. Black arrowheads point to joint narrowing in medial compartment of the knee joint. Laboratory features are normal in osteoarthritis. ESR is normal. Complete blood picture is normal. Rheumatoid factor is negative. Anti-nuclear antibody is negative. Synovial fluid show is clear yellow with good viscosity and positive string sign, with normal mucin clot, with slight increase in cell count less than 2000 per cubic centimeter, mainly lymphocytes and plasma cells, and there is no crystals under microscope and negative culture. What about treatment of osteoarthritis? Up till now, there is no medication or intervention which can reverse or stop the process underlying osteoarthritis. All the medication used to relieve symptoms and improve function. The first step in treatment of osteoarthritis is assurance and patient education. The patient should be educated about the nature of the disease, the prognosis, the side effects of the drugs, negative thoughts about inevitable progression and future life on wheelchair, and the patient should avoid exercise to avoid further destruction of the joint. All these negative thoughts should be opposed by an advice to the contrary. The patient should be advised to be active but within the range of common sense. The patient should be instructed to avoid overstress on the affected joints, as don't lie or sit too long in one position, don't use low chairs, don't stand in same position or walk for long periods, don't over-exercise the affected joints, don't squat, don't use faulty postures that place stress on affected joints, don't load the joint when it is very painful, reduction of body weight in obese patients, use proper footwear, regarding medications, use simple analgesic for pain. Paracetamol is the drug of choice in osteoarthritis. Non-steroidal anti-inflammatory drugs also used to relieve pain and relieve inflammation, but non-steroidal have many side effects, and peptic ulcer and gastrointestinal bleeding is one of the serious side effects of non-steroidal anti-inflammatory drugs. Our patients are old patients having other comorbid conditions like kidney disease, liver disease, taking multiple drugs, so this makes those patients at high risk for side effects of non-steroidal anti-inflammatory drugs. So when we give non-steroidal anti-inflammatory drugs in management of osteoarthritis, we must take some consideration. Number one, avoid combination of non-steroidal anti-inflammatory drugs. Use the least effective dose for short periods. Use after meals. Use prophylactic proton pump inhibitors. Also, we can use selective COX-2 inhibitors, which inhibit the inflammatory formation of inflammatory prostaglandin, so decrease the side effects of the gastrointestinal tract. The side effects of NSAIDs on gastrointestinal tract as peptic ulcer and gastrointestinal bleeding. But selective anti-COX-2 should be avoided in patients with cardiovascular disease. For pain relief, also we can use topical NSAIDs cream or topical capsaicin ointment. Intra-articular injection in case of osteoarthritis can be used in case of monoarthritis with signs of inflammation and effusion. I can aspirate effusion, then inject long-acting methyl prednisolone. It results in rapid effect and sustain for about 6 weeks, and I can repeat the injection after 3 to 4 months. Also, for moderate osteoarthritis, I can use intra-articular injection of hyaluronic acid derivative. This improves the viscosity of synovial fluid and may have anti-inflammatory effect. But this is taken as course of 3 injections, 1 injection per week for 3 weeks, and it is useful only for mild to moderate cases. It is useless in severe cases. Regarding chondroprotective drugs, ACR as a glucosamine, it is nutrient supplement. ACR not recommend the use of these drugs, as there is conflicting results about their effectiveness in decreasing pain and improvement of function. What is the role of physiotherapy in management of osteoarthritis? Physiotherapy has an important role because, as we said before, the medication have side effects in this category of patients. There are several modalities of physiotherapy which can be used in management of osteoarthritis, as heat modalities, as radiant heat, ultrasound, short wave, cold therapy, laser, massage, traction, spinal traction, exercise. Exercise is very important in management of osteoarthritis, which include strengthening exercises, as strengthening of the muscle decrease the load on the joints. Also, range of motion exercise to maintain a range of motion of the joint, stretching exercise in case of contracture, and also aerobic conditioning exercises, but avoid weight-bearing exercise. The benefits of physiotherapy include decreased pain, decreased stiffness, decreased muscle spasm, improve joint range of motion, strengthening periarticular structures, so improve joint support, and improve blood supply and metabolism of joint. We can use assistive device to partially unload the joint, as the knee brace, like this in this figure. Surgical treatment is indicated in advanced cases when there is very severe pain not responding to conservative measures, or there is loss of function where the patients can't walk more than 1 block or can't climb stairs. In this condition, partial or total arthroplasty can be indicated. Also, if there is angular deformity, osteotomy can be made to correct this deformity. Thank you.